and which is a very important clinical sign in the neurological examination. And I just want to talk in detail about this plantar reflex. Stroking the lateral aspect of the sole of the foot with a fairly sharp object produces plantar flexion of the big toe, the great toe. Often there is also flexion and adduction of other toes. So what you see is a flexion of the big toe and flexion and adduction of the other toes. Normally, if you stroke the lateral aspect of the sole of the foot. Often there is also flexion and adduction of the other toe. These are the two components, the flexion of the big toe and flexion and adduction of the other toes. This normal response is termed the flexor plantar reflex. In some patients, stroking the sole produces extension, that is dorsiflexion of the big toe, often with extension and abduction of the other toes, that is fanning of the other toes. So dorsiflexion of the big toe, fanning of the other toes. This abnormal response is termed the extensor plantar reflex or Babinski reflex. The Babinski reflex, the plantar reflex, was described by the neurologist Joseph Babinski in 1899. It's a very old clinical examination which made a huge contribution to the clinical examination of all the neurologists and the physicians to come to a conclusion there is a involvement of the corticospinal tract. Since that time, it has been incorporated into the standard neurological examination. So it is there almost 122 years in the clinical neurological examination. It has been incorporated into the standard neurological examination from 1899. The Babinski reflex is easy to elicit without sophisticated equipment. We don't need any sophisticated equipment to test the Babinski reflex. Since it is a reflex, it does not require active patient participation and can be performed in a non-cooperative patient also. If the patient is not cooperative also, we can do the test. It doesn't require much active participation of the patient. The technique is place the patient in a supine position. Patient should be in the bed in the supine position. To inform that we have to inform the patient what we are going. It's very, very important. Whatever clinical examination we are going to do, we have to tell the patient that before doing what we are going to do to the patient. Otherwise, the patient will not expect what we are going to scratch his foot or stroke the feet, that he may react in a different way. So it's better to inform the patient I'm going to scratch your feet, stroke your feet. So it may be a little ticklish, it may be a little painful. So we have to tell before start doing that. Are going to scratch the foot first gently, then more vigorously. Fix the foot by grasping the ankle or medial surface with the examiner's hand. So we have to grasp the ankle or the medial surface of the foot with the hand. That will be closest to the midline of the patient. Examiner's left hand when the patient's left foot is tested. So we have to stand on the left side of the patient when you are doing the left side the plantar reflex, and vice versa with the right foot. So we have to stand on the side of the test. We should not cross the patient while doing the test. Begin with light stroking using finger. So you can use the finger slowly you can stroke. Then use a blunt object like point of a key. You can use a key which will be more comfortable to the patient. Then suppose the finger is not inducing in a very severe pyramidal tract lesion, even if it tests, you will get the Babinski sign. But if it is a needle, you have to use a blunt object like point of a key. If no abnormal response was obtained, take a tongue blade and break it in off longitudinally and use the sharp point. That is the wooden tongue blade. Wooden tongue blade, you would have seen that it is like you have to vertically fold it, make it into two pieces, and use one of the piece for stroking the lateral aspect of the foot for doing the plantar reflex. If you are not able to, if you are not successful with the blunt end of the key or using the finger. The reason for the graded stimuli, light touch as with finger, frequently obtains the reflex without causing a withdrawal reflex. That makes the interpretation of the response difficult. So our main aim is to make sure we are not inducing a withdrawal reflex to the patient. Otherwise, the interpretation becomes difficult. So that's why we always start with a light touch with the finger. One cannot conclude the response is normal until a noxious stimuli is indeed used, since the reflex is a cutaneous nociceptive reflex. So we cannot conclude it is normal unless you grade and increase slowly the stimulus of stroke to come to a level that it is a cutaneous nociceptive reflex. We should not produce that kind of pain, but we have to make sure that we stroke enough to see the response. The first line to be stroked begins a few centimeters distal to the heel. So always start a few centimeters distal to the heel and is situated at the junction of the dorsal and plantar surface of the foot. So if you see the foot and if it is the junction of the dorsal and plantar surface of the foot, then that is the place you have to start stroking. The line extends to a point just behind the toes. So behind the toes, you have to go behind the toes and then turn medially across the transverse arch of the foot. So distal to the heel, in the lateral aspect at the junction of the plantar and dorsal surface, and stroke, then come to the behind the toes, and you cross the entire transverse arch of the foot. That is the way to stroke the foot to see the plantar reflex. Stroke slowly, taking 5 or 6 seconds to complete the motion. We should not do it very fast. Take around 5 or 6 seconds and stroke slowly, then you will get the proper response. We should not dig into the sole, but we have to stroke. We should not produce give a lot of pressure with the key or the finger or the tongue blade of broken tongue depressor blade, the wooden blade, and we have to scratch. We have to stroke. We should not give a lot of pressure to the patient. It will be very painful to the patient. Successive lines are stroked. That is, suppose we are starting the stimulus at the junction of the plantar surface and the dorsal surface. We are starting in the lateral aspect, the most lateral aspect. We have to use the successive lines. For example, each about 1 centimeter medial to the preceding stroke until the examiner is stroking the midline of the foot. So we have to come everywhere. The next stimulus should be 1 centimeter medial to that. Like that, you can go up to 4-5 lines until you are not crossing the midline. And because there is a scientific reason that you may get the response in the second stimulus, not in the first stimulus, if you go 1 centimeter medial to the and then the sole of the foot while stroking. The reason for beginning laterally is that in some cases, the response is abnormal laterally and then becomes normal as the midline is approached. So if you are starting with the lateral aspect, you may see the response, but if you go a little medially, you may not see the response. So that's why you have to start laterally and then you have to go 1 centimeter medially gradually. The occurrence of the extensor response on any of these lines is abnormal, even if the response is flexor on another line of stroking. So if you see that one stroke that you see the extensor response, after that it is seen as flexor, that extensor response is abnormal. You may see that kind of mixed, like one stroke you feel extensor, the next stroke if you go medially 1 centimeter, that may not be extensor. That doesn't mean that patient is normal. You have to correlate with all the other clinical findings like deep tendon reflex and everything together. The variation relates to variability in the receptive field of the reflex, amount to the extent of corticospinal involvement as well as the individual differences. So the variation depends upon so many factors, how extensive the corticospinal tract involved and what is the individual difference. All those factors plays a role. In a straightforward case, you will get the immediate plantar extensor response. But there are difficult situations. You have to use everything together, and you have to use all the techniques to come to a conclusion. And what is the response in the particular plantar reflex of the patient? The reflex is normal if the abnormal response is not obtained from any of the stroke lines using all of the stimulate descripts. Suppose you do 1 centimeter medially and go up to the midline, everything is flexor, then basically it is a flexor plantar response, a normal response. A good habit is to describe whatever response is obtained in addition to noting whether in the opinion the response is normal or abnormal. It's always better to describe what we see. Suppose we expect certain things, like for example, dorsiflexion of the great toe, then fanning of the other toes and everything. That's what we expect. But suppose you don't get that, it's better to describe what we see rather than trying to tell what we expect. It's better to describe what we see rather than what we're expecting. If you take the basic science, Kugelberg, Eklund, and Grimby in 1960, the EMG study, they've done extensive EMG studies, and they made a conclusion based on that, the basic science of the plantar reflex. The reflex is mediated by the spinal cord and mediated by higher centers. Noxious stimulus to the sole of the foot, which is the receptive field, causes immediate flexion of the toes, ankle, knee, and hip joints with attendant withdrawal of the foot from the stimulus. So if you stimulate you use the noxious stimuli, it is not only the foot response, that is the finger, the toes response. It's also that people have flexion of the ankle, knee, and hip joint. So you will see all the response together to the noxious stimuli to the sole of the foot. The own experience, for example, we see plantar reflex in day-to-day life without somebody stroking our foot. Own experience is stepping on a sharp object with a while barefoot. Suppose we are in a barefoot, no, we are going to some place in a barefoot, and some stone or something strike our foot. That it produces the plantar reflex. You see the flexion of the toes, and your ankle and knee and hip will flex subconsciously. That is a normal plantar reflex. What we experienced. The clinical significance. The plantar reflex is a nociceptive segmental spinal reflex that serves the purpose of protecting the sole of the foot. So the plantar reflex is a nociceptive segmental spinal reflex. It is the main purpose, is a natural given purpose is to protect the sole of the foot. So it is there for a purpose. The abnormal response indicates metabolic or structural abnormality in the corticospinal system upstream from the segmental reflex. The abnormal response is the patient has abnormal plantar reflex. It can happen in metabolic encephalopathy or metabolic insult to the spinal cord, or the structural abnormality in the corticospinal system like stroke, multiple sclerosis, and myelopathy due to so many reasons. So any spinal cord lesion, brain lesions, and structurally or metabolically can produce this kind of a abnormal plantar response, what we call as Babinski sign. There is disagreement whether the response is plantar flexion or dorsiflexion in the majority of newborns. So when you go and check a newborn, you have to be careful that it may be a normal response. Even the abnormal response can be a normal response. In all cases, however, the response does become flexor by the 6th to 12th month of life. By 1 year, it becomes the normal plantar reflex like adult. But there are some studies say it takes up to 2 years. So you have to be careful up to 2 years while interpreting the plantar reflex in a child. The receptive field for the extensor plantar response can be quite extensive. On occasion, the extensor reflex has been elicited by stimulating as high as the face. So even touching the face, touching the spine, some people get, because of the lesion, there's extensive involvement of the corticospinal tract. On occasion, the extensor reflex has been elicited by stimulating as high as the face. There are some documentation that the very bad involvement of the the corticospinal tract, it can happen. Even in the same individual, there is often shrinkage in the receptive field as the time passes after the occurrence of the lesion. For example, that if the patient has extensive demyelination, we give treatment, the demyelination shrinks, the patient becomes better. We have seen the extensive plantar the response, like up to the flexion of the hip and touching the face or the spine, produce the plantar abnormal plantar response, what we call as Babinski sign, can also disappear over a period of time, that if the involvement shrinks due to treatment, like some other condition like acute disseminated encephalomyelitis or some B12 deficiency producing myelopathy, and all these things that the patient become better after treatment, that you see that kind of extensivity in the response will come down with the improvement with the treatment. Equivocal. This is the important thing. Sometimes the student, the training person getting trained, the doctor getting trained, and may sometimes they're not very sure or confident. They may say the plantar is equivocal.
So, Dr. Palni sir, we could not hear you.
There may be flexion. Subsequently, immediately you may see there is some the abnormal component of following that flexion, which is initially considered to be a normal response. Babinski and Hopanim or Babinski and Gordon. Suppose we are not very sure whether it is a normal plantar reflex or Babinski sign, then we have to do other additional methods of eliciting Babinski sign, like Babinski and Hopanim, which I will tell what is Hopanim, or Babinski and Gordon. So you have to look for other ways of stimulating to get into the response where it's normal or abnormal. So you have to see the additional techniques of eliciting the plantar reflex. The Chadok sign is stimulating under the lateral malleolus. You stimulate under the lateral malleolus, then you may get the Babinski sign, which initially thought may be an equivocal plantar response. Very important that you do the Chadok sign. And Gordon sign is squeezing of the cough muscle. So you squeeze the cough muscle. Initially, you felt that plantar is flexor, or maybe it is equivocal. Then that way, that become abnormal Babinski, the abnormal plantar reflex or Babinski sign. It gives a clue that it is an abnormal response. Opening sign is applying pressure to the medial side of the tibia. So you apply pressure to the medial side of the tibia, then you may get the Babinski sign, which we are not sure while doing the plantar stimulation. This ought to be used only if we are not sure about the finding in the stimulation of the sole of the foot. And Throckmorton sign, hitting the metatarsophalangeal joint of the big toe. So if you hit the metatarsophalangeal joint of the big toe with a knee hammer, then you may get the response. It is useful in patients who have significant withdrawal response. And some patients are very sensitive sole, and if you touch itself, they withdraw it actually. And it is there the way they are actually. It is better to go on stroke and producing more pain to them. So you have to look for additional neurological signs. Also, you can use these techniques where you are not going to touch the sole of the foot. You are only touching the malleolus, calf muscle, and medial side of the tibia. So that can give you a clue that the patient has Babinski sign. The patient is a very, very sensitive sole, and the patient has a visual response to every stimulus used to the sole of the foot. So the triple flexion response can occur in comatose patient. Patient is comatose. You do the plantar reflex, the technique what I told you. You get dorsiflexion on the big toe, fanning of the other toes, dorsiflexion of the foot, as well as the knee flexion. So if you get all the response, which I told that the normal productive phenomenon of the plantar reflex, and that is called as triple flexion. Triple flexion response, nothing new. It is the total response, because you don't see all these response in a patient while doing that. But if you see that the patient has the dorsiflexion of the big toe, fanning of the other toe, dorsiflexion of the foot, as well as knee flexion, that is called as triple flexion response. You may see in a comatose patients, can occur in comatose patients, or sometimes in normal patients, extrinsic corticus patients. In the plantar reflex, I told that you get all this response. But if you get the abnormal Babinski with along with all the other component, that is called triple flexion response. The triple flexion response is very stereotyped, whereas the withdrawal response can vary with each stimulation. So how do you find out whether it is the triple flexion response or withdrawal response? Is triple flexion response is very, very stereotyped. Every time you do that, you will get the same response, whereas the withdrawal response can vary with each stimulation. That's very, very important. Hoffman sign, people say that is equivalent of Babinski sign in the upper limb. It was described by the assistant of German neurologist Johann Hoffmann. That is his assistant, the great neurologist assistant, and Hans Kussmann in 1911. He found out that Hoffmann sign actually. That is involuntary flexion movement of the thumb and our index finger when the examiner flicks the fingernail of the middle finger down. So when you flick the fingernail of the middle finger, if there is involuntary flexion movement of the thumb or index finger, that is called as Hoffman sign. Up to 3% of the population has been found to have a positive Hoffman sign. So it's very, very important. When you find that, always collaborate with other additional finding like a positive Babinski sign, and the patient has other involvement of corticospinal tract with brisk reflex, exaggerated reflexes. So you have to correlate this along with all the other clinical findings. Just if you find only Hoffman sign with no other corticospinal tract clinical signs, be careful telling it as a Hoffman sign. So as I was telling that it is not a standalone reliable sign. If it is a standalone finding, it is not a reliable sign. So thank you very much for listening to me. I just told that how important the plantar reflex, how old it's very. It is practiced for 130 years. It has given a huge benefit to the practicing doctors to come to a conclusion about the involvement of corticospinal tract, and it is a wonderful contribution by Professor Babinski, and which still is clinically valid and is applicable. And so we should not, we should methodically examine the patient. And as I told that there are so many methods of doing plantar in a very fast world with so much technology available. We should not, okay, I stopped it. I'm not very convenient. Anyway, I'm going to MRI of the spine, MRI of the brain. I'll make a diagnosis. That's not the way to do that. We have to practice all these clinical science. And one or other day that in day-to-day practice, it is useful. One or other day that we may totally need that in a very confused technological contribution, because too much technology also make us confused, and the clinical findings will be very, very useful to come to a conclusion. Thank you very much for listening to me.